Chapter 111, Introduction to the Motor System, that is the spinal cord. So sensory information is integrated at all levels of the nervous system, and it causes appropriate motor responses that begin in the spinal cord with relatively simple muscle reflexes, and then they extend into the brainstem with more complicated responses, and finally extend to the cerebrum where the most complicated muscle skills are controlled. So in this chapter, we'll discuss the spinal cord control of muscle function. See, for example, there is no neuronal circuit anywhere in the brain that causes the specific to and fro movements of the legs that are required for walking. The brain simply sends command signals to the spinal cord to set into motion the walking process. Okay? So the brain, it just doesn't have a small function. Okay, it to promote the turning movements when they are required, to lean the body forward during acceleration, all this is done through analytical and command signals generated in the brain. Okay, however, the many neuronal circuits of the spinal cord that are the objects of the commands are also required. So integration between the functioning of both the brain and the spinal cord is pivotal. So coming to the organization of spinal cord for motor functions, the cord gray matter is the integrative area for the cord reflexes. Sensory signals enter the cord almost entirely through the sensory roots, now also known as the posterior or dorsal roots. Okay. After entering the cord, every sensory signal, it travels to two separate destinations. One branch of the sensory nerve, it terminates almost entirely in the gray matter, okay, of the cord, and it elicits local segmental cord reflexes and other local effects. Whereas the other branch transmits signals to higher levels of the nervous system, that is to higher levels in the cord itself, to the brainstem or to the cerebral cortex. Okay, so each segment of the spinal cord has several millions of neurons in its gray matter. Aside from the sensory relay neurons, there are two types of neurons: anterior motor neurons and interneurons. Coming to anterior motor neurons, there are several thousands of these neurons, and they are 50 to 100% larger than most of the others. They are called anterior motor neurons. They are located in each segment of the anterior horns of the gray matter of the spinal cord. Okay, they give rise to nerve fibers that leave the cord by the way of the anterior roots and directly innervate the skeletal muscle fibers. They are of two types: alpha motor neurons and gamma motor neurons. Coming to alpha motor neurons, they give rise to large type A alpha motor fibers averaging 14 mm in diameter. Greater the diameter, greater the conduction velocity. These fibers branch many times after they enter the muscle and innervate the large skeletal muscle fibers. The alpha motor neuron fibers, they branch after entering the muscle, and they innervate the extrafusal muscle fibers, which cause the muscle contraction. Okay? Stimulation of a single alpha nerve fiber excites anywhere from 3 to several hundred skeletal muscle fibers, which are collectively called the motor unit. A motor unit is nothing but the single motor neuron and all the muscle fibers it innervates. Coming to gamma motor neurons, there are about one half as many much smaller gamma motor neurons located in the anterior horns of the spinal cord. They transmit impulses through much smaller type A gamma motor nerve fibers. They have a smaller diameter. They go to small special skeletal muscle fibers called intrafusal fibers. They do not take part in muscle contraction, but however they help control the basic muscle tone. Okay. And coming to interneurons, they are present in all areas of the cord's gray matter. They are small and highly excitable, and they often exhibit spontaneous activity and rapid firing. They fire as rapidly as 1500 times per second. They have many interconnections with one another, and many of them also synapse directly with the anterior motor neurons. Okay, so essentially all the different types of neuronal circuits found in the interneuron pools of the cells of the spinal cord, including diverging, converging, repetitive, discharge, and other types of circuits. Only a few incoming sensory signals from the spinal nerves or signals from the brain terminate directly on the anterior motor neurons. Instead, almost all these signals are transmitted first through interneurons, where they are processed. The corticospinal tract from the brain is shown to terminate almost entirely on spinal interneurons, before finally converging on the anterior motor neurons to control muscle function. Coming to Renshaw cells. Renshaw cells, they transmit inhibitory signals to surrounding motor neurons. They are located in the anterior horns of the spinal cord in close association with the motor neurons. So almost immediately after the anterior motor neuron axis leaves the body of the neuron, collateral branches from the axon of the alpha motor neuron or the anterior motor neuron, they pass to adjacent Renshaw cells. These Renshaw cells are inhibitory cells. They transmit inhibitory signals to the surrounding motor neurons. Thus, stimulation of each motor neuron tends to inhibit adjacent motor neurons. This is an effect that is called lateral inhibition. The motor system uses this lateral inhibition to focus or sharpen one particular signal in one particular direction. So coming to multisegmental connections, more than half of the nerve fibers that ascend and descend in the spinal cord are propriospinal fibers. These fibers, they run from one segment of the cord to another. Now coming to autonomic reflexes in the spinal cord, many types of segmental autonomic reflexes are integrated in the spinal cord. So these include changes in vascular tone resulting in changes from local skin heat. That is, if the heat increases, the smooth muscles, they cause dilation. Smooth muscles in the arterial walls, they cause vasodilation. And then the second one is sweating, which results again from localized heat. And third, intestinal reflexes, peritoneointestinal reflexes, and finally evacuation reflexes for emptying the full bladder. In addition, all the segmental reflexes can at times be elicited simultaneously, and this is called a mass reflex. So in a spinal animal or human being, suddenly sometimes the spinal cord becomes excessively active, causing massive discharge in large portions of the cord. The usual stimulus that causes this excess activity is a strong pain stimulus to the skin or excessive filling of a viscus such as the bladder or a gut. This reflex, called the mass reflex, involves large portions of all or even all of the cord. So the effects are as follows. Again, a major portion of the body's skeletal muscles go into strong flexor spasm. The colon and the bladder are likely to evacuate. The arterial pressure often rises to maximal values, and large areas of the body break out into profuse sweating. So because a mass reflex can last for minutes, it presumably results from activation of great numbers of reverberating circuits that excite large areas of the cord at once. This mechanism is similar to the mechanism of epileptic seizures, which involve reverberating circuits that occur in the brain instead of in the spinal cord. Coming to spinal cord transection, when the spinal cord is suddenly transected in the upper neck, at first, essentially all the cord functions, including the cord reflexes, immediately become depressed to the point of total silence, which is a reaction called spinal shock. The reason is that normal activity of the spinal cord neurons depends to a great extent on continual tonic excitation by the discharge of nerve fibers entering the cord from higher centers. So after a few hours to a few weeks, the spinal neurons, they gradually regain all their excitability because of regeneration of the nerve fibers. Because this is a natural characteristic of neurons everywhere in the nervous system. That is, after they lose their source of facilitatory impulses, they increase their own natural degree of excitability to make up for at least partially for the loss. Okay. But in most non-primates, excitability of these cord centers returns to normal within a few hours or a few days. But in human beings, this return is often delayed for several weeks and occasionally is never complete. Conversely, sometimes recovery is excessive with hyperexcitability. Nevertheless, the recovery of reflexes is insufficient to bear the weight of the person, and hence it is not possible for the person to stand unsupported. Okay. So, some features of spinal shock are the following. At the onset of spinal shock, the arterial blood pressure, it falls almost instantly and drastically, and sometimes to as low as 40 mm of Hg, thus demonstrating that sympathetic nervous system activity becomes blocked almost to extinction. Okay. The skeletal muscle reflexes, all skeletal muscle reflexes integrated in the spinal cord are blocked during the initial stages of shock. They again, in lower animals, return to normal in few hours to few days, and in human beings it takes 2 weeks to several months. In both animals and humans, some reflexes may eventually become hyperexcitable, particularly if a few facilitatory pathways remain intact between brain and the spinal cord while the rest of the spinal cord is transected. The first reflexes to return are the stretch reflexes, followed by comparatively complex reflexes such as flexor reflexes, postural anti-gravity reflexes, and remnants of the stepping reflexes. Again, the sacral reflexes for control of bladder and colon evacuation are suppressed in human beings for the first few weeks after cord transection, but they also again eventually return. A hemisection of the cord, that is transection of half of the cord on any one side, can occur due to expanding tumor of the cord or injury. So there are a unique set of signs here. There's a unique set of signs here. There is an ipsilateral upper motor neuron paralysis below the lesion due to interruption of the corticospinal tract, which supplies anterior horn motor cells on the same side, ipsilaterally below that level. So UMN paralysis below that level, ipsilaterally. There's also a possibility to demonstrate a lower motor neuron paralysis ipsilaterally at the level of the lesion. Okay. There's also a loss of superficial reflexes, loss of proprioception, 2-point discrimination, and vibratory sense ipsilaterally due to interruption of the posterior white columns, fasciculus gracilis and cuneatus. However, pain and temperature sensation is lost on the opposite or contralateral side below the lesion due to the interruption of the lateral spinothalamic tract, whose fibers originated on the side where opposite the lesion but which crossed in the anterior white commissure. This is also called the Brown-Séquard syndrome. Coming to tabes dorsalis, it is a disorder of the spinal cord due to demyelination of the dorsal columns. In the name itself, there is dorsalis, okay? There is demyelination of the dorsal columns in tabes dorsalis. It is a result of untreated untreated syphilis, and it is quite rare. These columns, they carry the sensations of fine touch, vibration, and position. So there is decreased tone of muscles with diminished tendon reflexes. There is a loss of coordination and characteristic high stepping gait. Okay. Coming to syringomyelia, it is another disorder of the spinal cord due to the formation of a fluid-filled cavity in the central cord. This puts pressure particularly on nerves that cross at this point, which are the afferent nerves carrying pain and temperature sensation to the anterolateral tract. The primary symptom, therefore, is a loss of thermal and crude pain sensations. The cavity or cyst can be congenital or acquired due to trauma or infections, and it is also called as syrinx.